Good morning, everyone. Good morning, and welcome to the 2017 Data Forum. You braved the rain to join us this morning. Thank you. For people in the back, please come join us. There's seats up front in the front row. You won't get called on, and I heard you get the best grades when you sit in the front row. Please join us. My name is Rochelle Seeger. I work at the Foundation for a Healthy Kentucky as a Community Health Research Officer. I'm honored everyone came this morning to join us at the 2017 Data Forum. For opening remarks, I'd like to welcome the President and CEO of the Foundation for a Healthy Kentucky, Ben Chandler.
Thank you, Rochelle. Appreciate the opportunity to be here. And to all of you, good morning. Glad that you weathered the rain. I almost didn't. I had to drive up from Louisville, and a few of you may have also done that. Whoever did, they're brave and hardy souls, because it was a torrential downpour coming up this way. Got a little better when you got up to northern Kentucky. Today's forum is an exciting thing. It's bringing together many in our region who certainly are interested in health and are interested in data. Underlying our work at the Foundation for a Healthy Kentucky is a focus on improving access to care, reducing health risks and disparities, and promoting health equity. And data innovation and collaboration can be a way to get us there. Indeed, it's utterly crucial. We don't make a move, we don't do a thing in the policy arena at the Foundation unless it's supported by data. Now, that would seem to be obvious. It would seem to everybody here, I'm sure, that you ought not ever do anything unless it's supported by the data. But we live in an interesting time, the time of fake news. Who knows what to say about all of this? It does get to be frustrating from time to time when you offer data, you've got facts, and somehow they get distorted and people don't listen to them. So anyway, that's another story altogether, and we've got to deal with that to figure out how to move ahead on the things that we want to move ahead on. Improvement will require a comprehensive approach, certainly, that includes epidemiology and surveillance, data and research to guide, prioritize, deliver, and monitor programs and population health, environmental approaches, making healthy behaviors easier and more convenient for more people, healthcare system interventions, improving delivery and the use of quality clinical services to prevent disease, detect diseases early, and manage risk factors and move to a preventive care system. Community clinical links, ensuring that people with or at high risk of chronic diseases have access to quality community resources to best manage their conditions. Today at the Foundation, we are focusing our efforts on smoke-free and tobacco-free policies. Why? Because the data demands it. You all know what the data is on these subjects, but I'll just give you a few data points. Cancer. The Commonwealth of Kentucky is #1. In other words, we have the highest cancer rate in the United States of America. Now, ladies and gentlemen, that cannot stand, but that's what the data shows. We have more cancer per capita than any other state in this country, and our cancer mortality is the highest. Not coincidentally, we also have right at the highest smoking rate in the country. So, how are we going to deal with the cancer? One of the obvious ways that's at hand is let's be serious about doing something about the smoking rate here in the Commonwealth. We know, again, the data shows us that there are a couple of things that actually will affect it. Smoke-free laws will cause the smoking rate to come down and ultimately the cancer rate to come down. Hiking up the tax on cigarettes will also cause the smoking rate to come down. We know this. We have data that shows that this is the fact. So, we're about the business of trying to do these two things. We are trying to get smoke-free laws all over the Commonwealth, and here in Northern Kentucky is a particularly ripe place for us to get working on that subject. Lexington and Louisville have smoke-free laws. We don't have them, comprehensive smoke-free laws, here in Northern Kentucky. We also need to raise the tobacco taxes by at least $1 or more per pack, with parallel increases in other tobacco products. And to this effect, we're making an effort now by launching, in fact, we did it just last week, the Coalition for a Smoke-Free Tomorrow. It's a new coalition that is committed to reducing smoking rates and exposure to secondhand smoke in the Commonwealth. We are determined to be successful, and we're determined to work at it as long as it takes. Today in this room, we have representation from local and state health departments, community nonprofits, hospitals and clinics, universities, healthcare organizations, and more. And it will take all of us working together to improve the health of our region. I don't need to tell you, we have to use data to improve health. And that's why we're here today. We're very proud to again partner with Interact for Health to present this 2017 data forum. We look forward to a great day. Thank you.
Good morning. My name is Mark Carrozza. I'm with Health Landscape. I'm also one of the co-presenters or co-sponsors for today. Health Landscape is a social enterprise that's been around for about 15 years. We sort of work with the overlay between personal health, individual health, and community data. If you're not familiar with Health Landscape, come out by the table and we'll tell you a little bit more about it. If you're familiar with us, come by anyway because we've changed a lot in the last couple of years. I've been attending this conference for some number of years. And one thing that I learned a long time ago was that there are two things that you need for this conference to be successful. The first is a great panel of speakers. And if you look across the agenda, we've got some really interesting people. Susan's put together a really great set of speakers today. I know some of them personally, most of them I know by reputation. It's going to be a really great set of stage speakers. The second thing that's really sometimes more important is having an engaged and enthusiastic audience. That is the people out there. Whenever I come to a data conference or data forum like this, I always come with my own personal checklist of things that I want to hear about. So right now, I'm really very much interested in social determinants of health. A few years ago, I was very much into healthcare workforce. It always changes depending on the conference, it depends on what I'm trying to do. So I'm hoping that all of you have something in the back of your head that when you looked at the agenda, I'm looking for social determinants or I'm looking for health workforce. Does everybody have something like that in the mind? Yes? Yes? Yes. Okay. So what we're going to do, this is actually the important part of the welcome. What we're going to do like church. We're going to get up. We're going to introduce ourselves to all of our neighbors and tell them, I'm here because I'm interested in social determinants. I'm here because I'm interested in healthcare workforce. So let's stand up, turn to your neighbors and say, hi, I'm Mark. I'm here interested in. Wonderful, wonderful.
Yeah, I don't know what you started here, but you may not be able to stop it.
Okay, All right. It's one thing to be enthusiastic and engaged, and it's another one to just, That was phenomenal. I'm really glad that you did that, believe it or not, because I've been to enough of these things that I know that the meat of the conference happens in these tables, happens out in the hallway, happens out at lunch. That's where connections are made. If you look at the history of my own organization, Health Landscape, I'm sure that 14 years ago we sat at a similar data conference here and talked about, hey, wouldn't it be nice if we had mapping around health? And here we are 14 years later still having that conversation. So I'm hoping, I believe that the conversations that you had today just now will last for days, weeks, months, possibly years. Welcome. Thank you.
Hello, everybody. The third and final welcome. I am so happy to be here with all of you, my fellow data lovers, and to be on the stage again with some of our best collaborators, the Foundation for a Healthy Kentucky and Health Landscape. I wanted to talk briefly about Interact for Health. We are a health foundation that serves the greater Cincinnati region, including counties in northern Kentucky and Indiana. We've recently launched a new strategic plan, which you can read more about online, but our focus is now on tobacco, opioids, and school-based health centers. Many of those you will hear data about today, including from some of our own talented staff. So this is the fourth time we've collaborated with the Foundation for a Healthy Kentucky to host this conference, and I wanted to find out who has been here before. So raise your hand if you are a hardcore health data groupie and you've been here before. Excellent. Raise your hand if you're going to come again. Everybody. Okay, who remembers when we did this in 2011 at the Northern Kentucky Convention Center? Raise your hand if you were there. All right, excellent. Okay, here's another hard one. Who has their button from last year which says, I know Mark Carrozza? Anybody? Anyone still have the button? I do. So speaking of buttons, we think jewelry is important. Outside, you will find a button maker. There are pre-made buttons. Mine says, let's talk about data. There are I love data. There are a number of pre-printed choices. You can also write your own. I encourage you to make one or several to take home with you. It's really a fun gadget, high-tech gadget. I did want to take a moment and thank the two people who have really put all the blood, sweat, and tears into that, and that's Susan Sprigg from Interact for Health here, and Rochelle Seeger from the Foundation for a Healthy Kentucky. Thousands of emails have been exchanged, probably many of them in last night, so they did a terrific job of bringing us a great agenda, and I welcome all of you. Thank you for coming to talk about such an important issue. Rochelle?
Jennifer Chubinski. Thank you. Thanks so much, Ben and Mark and Jennifer, to welcome us this morning. This is what happens when you get data people away from their computers. They just start talking and networking, and right? The data people didn't laugh, but the people on the podium laughed. I'm so glad all of you are here today. You'll note we have a hashtag for the Twitter peeps in the audience, so please feel free to tweet. Many of the speakers and keynotes hashtags, their Twitter handles are on your agenda today. Also, we will be recording today's session, so you can watch it later, or if your colleagues weren't able to attend today, we'll be recording the session here this morning. Mark mentioned the networking, the connections card and the table just outside in the lobby. Please feel free to fill that out if you're shopping a project that you're doing. Set that out in the connections card table in your lobby. And I'm not Craig Bramer, as you can plainly see. He's stuck in traffic, but I'm going to welcome our keynote this morning, Aaron Truchil, to the stage. So please help me join me in a round of applause for Aaron. As Aaron makes his way to the stage, I'm going to give you the backstory. I'm a data person. Some data people might say they're introverts, so I'm an introvert. I was at a great conference sponsored by Robert Johnson called 500 Cities. I had the opportunity to attend. So it was the second day, early in the morning, and I go to the breakfast. They have a beautiful breakfast spread. I look around, and I'm just like, I'm not feeling it. I don't want to be social this morning. I just want to sit at a table. Then I look, and I'm like, oh, okay, there's a table with one guy who looks really nice. Maybe he's an introvert like me.
True.
And I had the good fortune of meeting Aaron Truchil there. And of course, I knew about Camden Health and the work that they were doing. A number of years ago, the Foundation for a Healthy Kentucky brought Dr. Jeffrey Bremer to Kentucky to talk about the hotspotting work that they were doing. And here he is today. Craig is not here at the moment. Craig, if you're here, okay, let's talk about him. So I've been back and forth with Aaron a little bit on, can he come to the data forum? We'd love to have him in Kentucky. Our schedule's going to work. Just a few weeks later, I got a call from my colleague Susan Sprigg, who you saw here this morning from Interact for Health, and she's like, Craig Bramer from the Health Collaborative wants to bring in this guy. He's from Camden Health. His name is Aaron Truchil. I was like, let's do it, Craig. So thank you to Craig for helping us bring Aaron here today. Thank you to our sponsors, Foundation for a Healthy Kentucky, Interact for Health, and our supporting sponsor, Health Landscape. Please help me welcome Aaron Truchil to the stage this morning. Aaron.
I've got two clickers, so we'll find out just in a moment which one works. But no, thank you so much, Rochelle, for the very warm introduction. This is actually my first time in the bluegrass state, and now I know, why it's bluegrass, because there's so much rain, I guess. Is that the secret to it? But actually, my family, my mother's father was born in Bardstown and grew up there. I'm not sure precisely how close that is, but he passed away when I was very, very young, 6 or 7 years old. But I have a distinct memory of him showing me his bootlegging moonshine distillery. So that's my impression of Kentucky. And my mother ended up growing up in Cleveland, Ohio. So lots of trips to Cleveland. I see some Cleveland supporters in the audience. I've never been to Cincinnati, even though she went to Edgecliff, which is now part of Xavier, I guess. And so, I'm excited to be here. The only thing that she recommended that I do, and I'm hopeful that I can get some more suggestions, is to go to Grater's Ice Cream. So end of season, I will try and get very warm today and then go over there. If you have suggestions, preferably things inside, though, I would absolutely love them. So I think actually it is the other clicker. I'm sorry. So when I was thinking a little bit going today about some of the key lessons that I wanted to instill, I have some interesting data work that we're doing back in Camden, New Jersey that I think will have valuable lessons. There's a really great agenda, as you've heard, touches on everything from how data can be used at the local level to the state level to how to bring cross-sector partnerships together. And so just sitting outside before we started, I thought that I was hearing lots of interesting conversations around data sharing agreements and lots of highly relevant things that we need to be talking about, but just some high-level themes that I think are really important to the work that we're doing. And so I know that this is a data forum, so this is probably a relatively easier question to push on people, but do we all think of ourselves as data people in the room? Does anyone here want to be brave and say that they don't think of themselves as a data person traditionally? I see a few hands. One of the things that we talk about at the Cabmen Coalition is, whether you're a nurse, whether you're a program director, whether you're a policy person, we all need to consider ourselves data people. And there's some advantages of that. Being a data person, you generally, you hate getting dressed up. You can see, you hate the tie, and you hide behind the desk most of the time, and you can just focus on your work if you're an introverted person, like myself and Rochelle. But really, it's thinking of ourselves of how do we look at data, how do we question it, how do we know to ask the right questions. Even if we're not the person that's predominantly interacting with the data, we are all part of the systems that are generating data and need to be able to tap into that to help us with our work. At its core, data is about relationships between people and systems. And so being able to tap into data as a tool to understand and shed light on what those relationships look like is going to be really integral to all the work that we're doing. And our job as collective data people, even the people that raised their hand just a few moments ago, is to capture those relationships. And that's going to be through effective analysis, which looks like presentations, it looks like nice data visualizations, and telling an effective story about the data. And lastly, just that effective analysis is more about building trust. Trust with the data generators, with the people that are in the data sets that we're using, with the communities that surround them. And it's less about complex, fancy math. Now, there's a place and there's a few points in my presentation where I'll talk about some more, use some more complex math pieces to it, and I'll try and point those out. But most of what we need to do is building relationships and trust that allow us to share the data, to have the conversations where we understand each other and can really support one another through the data. And that's really a relational piece. So when we talk about how do you build your data team, and I'm sure that there's some PhD and level researchers or data scientists in the room, and that there's an important role for that. But the biggest number one ingredient for your data team is, do you have people that can relate well with one another and have good conversations and build rapport. So I'm going to start by telling everyone a little bit about the Camden Coalition. I'm sure some of you have heard pieces of it, but I think it's an interesting, it's a relevant context to have in the context in how we use data. So the Camden Coalition started 15 years ago by a man named Jeffrey Brenner. He was a radical family doctor. I'm sure many of you have a few of those in your lives, who wanted to come back and serve in a underserved community after his residency program. So he settled in Camden, New Jersey, not too far from where he grew up. He spoke Spanish, and it was a large Hispanic community, and so came back and started his own primary care practice. You see him standing in front of it there. And it was pretty quick that he realized that just structurally it was a flawed dream. He was running from room to room to room. He was getting billed $15, $20, $30 from Medicaid for those visits, feeling like he was delivering meaningless units of care and not really able to build the relationships with his patients that he thought was critical to improving the quality of care. Meanwhile, down the street we have multiple health systems that were building fancy new emergency departments, new hospital wings, and so this sort of disparity between what was the core piece of what we recognize to be healthcare, of primary care, was just being heavily neglected. And so the Camden Coalition was an effort for him to essentially create a support group for himself and some of his collaborators. They started having monthly breakfast groups. It was very informal, just the provider community to come out and talk about what were the challenges that they were seeing, how could they support one another, and over time it's grown into a much larger and larger organization. So today the Camden Coalition is a little over 100 staff people. We're a community accountable care organization, and what that means is that our membership is hospitals, primary care providers, social service organizations, community organizations and representatives who are coming together and trying to have a conversation over how do we improve the quality and reduce the cost of healthcare in our community. So New Jersey, if you guys aren't aware, is doing some interesting Medicaid payment reform work. And so there was a Medicaid ACO demonstration project a handful of years back that basically created community accountable care organizations, which are geographic entities in more dense urban areas that have the membership that I just mentioned, hospitals, primary care practices, and community coming together to problem solve, and it creates a vehicle to then negotiate with the state or with managed care, that if you can then implement programs that improve quality and reduce costs, you can then bring that back in and start to realize those savings. Data has always been core to how we start to initiate that conversation. So that structure that I just mentioned, we in many ways see ourselves as a Switzerland-like force. And Switzerland is a really tough place to be in, in the world, and in a place like Camden. We're in the midst of a whole mix of different partners that have a whole different set of interests, priorities, and how do we use data to help come to a common understanding is really critical. But it's not an easy process, and it's not something that happens overnight. 15 years is a long time to cultivate those relationships and trust, but it's very iterative, and it's starting with what can we do to help people today and build towards the vision that we want to be moving towards. So has anyone here been to Camden City, just out of curiosity? See a few hands. Philadelphia, maybe that will bring a few more hands. Okay, so Camden is right across the river from Philadelphia, obviously one of the major metropolises. Interestingly, both sides are competing for the Amazon headquarters too, as I heard that there's some folks or cities in this area that are as well. So fingers crossed that one of us gets it, but we shall see. But anyway, this is preaching to the choir in that we really need local data in this work. And so if you're not familiar with Camden City or Camden County, we have a relatively affluent Camden County that's the suburbs of Philadelphia, lots of affluent suburban towns that surround it. Camden City itself, though, is among what's probably very common in many of the cities around the country, the post-industrial, jobs leaving, population shifts. And so when we tried to have a local understanding of what our health needs are, it's a very complicated space. And I know that this is a conversation that you guys have been having, I'm sure, at past data forums and amongst your organizations. But based on every single statistic that you can think of, things look very much different if you look at it at the city level when there is data that is available. And so one of the core things that Jeff, our founder, wanted to do when he was organizing the Camden Coalition was to have data be the central piece in trying to understand what was Camden's plight. And so we started with the hospitals. And now the hospitals are both great partners and a great start to this work. It's also a complicated entity to get to know and start to build relationships with. So here in Camden, we actually have 3 health systems. As many health systems are doing, there's actually been a recent merger and acquisition. So one of them is in the process of buying the other, and we're still trying to figure out what the implications of that. But very early on, we got those 3 health systems to enter into a data sharing agreement, and that was a very sort of serendipitous event. We Camden, among the many things that gets publicity, is its crime, and it's being rated as the most dangerous city, which is obviously a title that we hate to hear. But we realize that a lot of that violence is happening unreported, or there's not great ways to capture it and be able to shed light on it and have real conversations about it. And knowing that a lot of those assaults and people being victimized are coming into the EDs, and if we could just tap into that ED data, that we could then start to have a really compelling argument for why we need to start to do it, because not only is it morally and atrocious on so many other levels, but now we're talking about financial costs, and financial costs can start to bring people to the table. So we started a data sharing agreement with each of those hospitals, and we built a citywide all-player hospital claims data. So every single time that, say, Aaron Truchil went to one hospital and then went to another hospital, we were able to link that and understand that trajectory across the system. And a whole host of insights started to come out of that. So we found for a city that's 75,000 roughly people at 9 square miles, we're spending a tremendous amount on hospital-related care. So 132 million in 2014 was spent on hospital-related care for 77,000 people. And that's predominantly Medicaid and Medicare dollars, spending lots and lots of resources. Even more profound though, we saw that over half of the population is visiting the hospital on any given year. And even more profound was just the extent to which there's overlap. So if you look at a 1-year span, you see 23% of the population is going to multiple health systems. You expand that out a few more years and you see that it jumps up significantly. And so these are health systems, maybe they're buying themselves now. Historically, they've competed tremendously with one another. They've sued each other, and to think about how they can come together and serve these patients better, that is not the status quo in a place like Camden, as I imagine it's in many other communities represented here. This is just another way to show that. So we now have within that all-payer claims database a few additional health systems, and it's not just limited to Camden City, but you can start to see this shows the core darker square is the amount of shared patients across other health systems. And you can see for a large chunk of our hospitals, most of their patients are being seen elsewhere. Interestingly enough, if you look at the behavioral health subset, anyone who's going for behavioral health related care, this is this bottom right network diagram, you can see it jumps up significantly in that the behavioral health population is even more likely to be going across multiple health systems. It makes sense. I'm sure if you're in this space, that's something that rings true to you and it's intuitive. Having the data to tell that is one way to start to bring people together to the table. And so we have a whole variety of initiatives related on how do we bring the health care systems together to be a driver and collaborate more effectively around behavioral health care in the region. This is the trend that's become all too commonplace in this conversation, and so it's probably rather ubiquitous for everybody. But this idea of the concentrations of costs, and so in a place like Camden, spending $130 million in hospital-based care, that spending is highly concentrated in a small subset of individuals. So we've looked at this in so many different in payers and different communities, and this general trend plays out of 1% of patients, roughly 30% of our costs. Our work has really been about trying to understand who those 1% are. We think that it's a profound opportunity to understand systemic failures and be able to start to have real conversations around how do we improve healthcare, social services, and a whole variety of other factors. And it's, it's an easier conversation to be had because these are not patients that, the hospitals that I just mentioned are fighting over. Yeah, they're bringing in some money into their systems, but they're generally, the more difficult, the individuals who are coming in and causing the providers to be burnt out, realizing that they can't do anything, or, it's predominantly Medicaid and there's not as high reimbursement. So it's a really sort of right place to start, thinking about how we can improve our healthcare systems. Now, one of the key aspects that we always think about when we're talking about data, and this goes back to the themes I was mentioning, is how do we tell an effective story with data? And so this is zooming in really deeply, one person whose data has been anonymized, but this is based on real data, trajectory through our hospital system over a 5-year period. So I know it's a lot to see, and if you can, the slides will be distributed if you want to look closer, but each one of those ticks is a hospital visit. So we're talking if it's red, it's an ED visit, if it's blue, it's an inpatient stay, and the width of it is dictating its length of stay. And then we've laid over top of that each of the diagnoses. And so, this is just one person's trajectory, but you can already start to see the sense of progression, of escalation. So what starts as maybe a car accident where somebody breaks a bone and is prescribed some opiates, then spirals out into, repeated visits, escalation of mental health and substance abuse diagnoses, a whole variety of social related diagnoses. And so it's just a tale of tragedy. And, this is something that we all know. And now with the data, you can tell it in a cohesive way. You can attach each one of those hospital visits to a cost, it's charges and receipts and a payer, and we can have a really conversation over, is this the best way that we want to be spending our money? Clearly people are getting paid as a result of that, but is the patient actually benefiting? So we took that data and we've done a whole variety of different analyses. We've mapped it, taking advantage of the demographic data, so you can turn those addresses into X and Ys, start to look at geographic hotspots. So, these things have also become more and more common throughout, but when we were starting this off, this wasn't as much of what people were focusing on. Is, we have buildings and neighborhoods that are costing millions and millions of dollars in hospital-related care. And so we use this, less of our work is place-based. I know that there's a few people here talking about place-based interventions today, and we totally respect that. We've been more on the, how do we drive that small subset of patients that are coming again and again, and there's place-based related aspects to that, but we're not a place-based intervention. But maps are a really effective tool, as I'm sure many of you are aware, for getting people to start to relate to the data and understand it. What you're looking at is essentially a scatter plot, where on one dimension you have latitude and the other one you have longitude, and then, your colors are your intensity, and you can start to tell a story that people who live there or work there can, deeply relate to it. And so we found buildings that were, millions and millions of dollars, and we started to do community organizing, starting to get to know the organizations that were working very closely with those buildings, and start to understand, what do we need to do to change that trajectory. As I said, we've been focused on the 1%. That population, when you look at, tends to have multiple chronic conditions. In a place like Camden, it's the age, because the life expectancy has been so depressed, it's much, much lower. So we're talking 57 years old. In a given year, someone who's had 5 inpatient stays, 4.5 ED visits, ends up spending 55 days roughly in the hospital at a cost of $75,000. So, none of this is shocking, but I think it's a really good point to have the conversation over, is $75,000 to treat this subset of the population the best way to spend our resources? When we start, and so, we got access to that data. It was for looking at a small problem of violence, not a small problem, but a specific problem of violence in the hospitals. And, I think it was sort of made even more profound because, Dr. Brenner, our founder, he knew what he was getting paid for on the Medicaid side, that $20, $30 increments. And then to see that same person showing up on the hospital side, an ED bill for $500 for a head cold or, whatever things that should be treated in the primary care setting, it was infuriating, as I'm sure you could expect. And so we wanted to, start to build a model that would start to keep people out of the healthcare system for these avoidable types of visits. And so when we looked around, this is about 10 years ago now, most of the interventions that were being developed were very much focused on a specific disease cohort. So you had your diabetes programs, you had your heart failure care transition models. And, we started to look at the patients, we started to, have real conversations with our partners, and it became clear that, it wasn't the diagnosis that was driving that complexity and that, trajectory that I just showed you. It's something underlying. I mean, there's part social, there's part behavioral, there's the environmental context. but it wasn't the diagnoses. And the diagnoses obviously needed to be addressed, but you could find complex patients scattered throughout all these different diagnoses, and they had more in common with one another than they have with their cohort of people with that disease. And so hotspotting has really been about trying to not take a disease-centric approach, but to understand what is that underlying driver and start to segment the patient, not based on diagnosis, but based on complexity. One way that we've done that I think is a very simple way to do that is around utilization. So you can imagine, of the population that I showed you earlier that goes to the hospital any given year, you might have someone who comes into the hospital one time per year, comes to ED visit, very low cost. Age could be variable, but pretty healthy. But then you can start to look at the extreme, and you can start to see a sub-pocket that goes to the ED a lot, or gets admitted a lot and ends up costing $400,000 charges, multiple chronic conditions, versus say a subset that's going to the ED again and again and not getting admitted. And you can start to pull apart the population and start to think about what are the types of interventions. It's not one size fits all. It's about trying to segment the populations that we're working with out into meaningful groups and start to understand what those drivers are. So that is at its core the data piece that sort of got us in this pathway. Healthcare hotspotting, people have come to use it in a lot of different ways now over the years. We define it as strategically using data to target evidence-based services to complex patients. There's lots of different ways that you can define complex patients. We predominantly use utilization-related criteria just because it's something that people, it's measurable, it's simple, it's understood by our partners, it aligns with quality metrics like readmissions and a lot of things that people are talking about. And what we think is, at its core, is these patients are experiencing a mismatch between what their needs are and what their services are available. Yes, you can come into the ED, you can get admitted, you can get a warm bed, but are you getting the services that make sure that you have a smooth transition when you come back out to the community, or if you need housing or behavioral health, those things just aren't there. And so that's the mismatch at its core. We have 3 core data systems that support the work. So I talked at great length so far about just one of them, the all-payer claims database. That's this section on the right that we call an integrated longitudinal outcomes database. And we're going to talk more about that in just a bit, but we've now expanded it not just to hospital claims, but to a variety of other data sources. And this is much more static. It's not a real-time data set, but it allows us to understand our population, to evaluate our programs, and is a really sort of important foundation for the work. We also run a health information exchange, and so we need really at its core a platform to share data across partners. So the claims data are great. They tell that financial story. They're standardized. They're being collected as part of the routine process of care. But if you're going to rely on them to do your work, you need a much more real-time engine. And so we have a health information exchange that's pulling in real-time data. Lastly is this third system on the left. It's internal performance and care tracking. We need flexible tools that as we develop programs, we need to be very rigorous in how we model them and how we capture data around them so that we can then evaluate them and deliver them both at high volume and high effectiveness. So these 3 data systems kind of come together in a sort of interesting way, and they support all the aspects of the work that we're doing. So as I mentioned, the health information exchange, that's the real-time driver. So every morning we have a whole variety of different reports that are coming out on a daily basis. Who's been admitted, who's met certain clinical or utilization-related requirements. Somebody's job is then to be the traffic controller that then steers people to the appropriate intervention. So we take that real-time list. Somebody's doing a very intensive, we have ways of capturing the quantitative pieces of this, but we really feel like having a human person, especially when you're talking about a city and this scaling, it generally works pretty well, to go into the medical records, read the social work notes, read a lot of the other sort of deeper stuff that's not as easily quantifiable, and start to make the determinations around some of that stuff with natural language processing and some other fancy ways to potentially do that. There's ways that we can potentially automate that, but for the volume that we're working on, it tends to make sense. Key piece of hotspotting is the bedside engagement. So, as I'm sure if anyone here has dabbled in this space or, does this work, it's really hard to find complex patients when they're outside the walls that we work within. And so, that daily feed of hospitalizations, that's an opportunity where somebody's known, and, if it's an inpatient stay, you have a few days to start to build that relationship. And so, we really think of the hospitalization as a catalytic event. It's obviously not a great moment for most people's lives when you've been admitted. Behavior behavior change. It's an opportunity to have a conversation around how do we start to change that trajectory. So we get the person while they're known in the bed. We start doing a very person-centered care planning where, it's not just us coming through a checklist of these are the things, smoking cessation, mental health, housing. We let the patient first and foremost start out with what does their needs look like. So they, free-form write that down, and then we have a structured way to start to organize that into different themes and buckets. But at its core, it's not us telling them, it's them telling us. We then, we start the care planning as soon as we can. So if they're in the hospital, that's a few days head start, but it's really about how do we smooth out that transition back to the community. And so our teams, I forgot to mention, are, interdisciplinary care teams. We have nurses, social workers, community health workers. We have behavioral health specialists that help out in various cases. So it's a very interdisciplinary program. And so once the person's agreed to enroll into the program and we start to build out that relationships, we wrap a team around them depending on what their needs are. The most important piece that we found, and I'll talk about this in just a second, is getting to them very quickly after they've been discharged. And so it's a roughly 3 to 4 month program in this model. And so we focus on how do we get to their home within 7 days, how do we get them into a PCP visit within a week as well, a primary care visit. And then how do we build a sustained, repeated relationship with them? How do we begin to incorporate primary care and the providers into the fold and start to accompany them to their primary or specialty care and start to serve as a liaison and connector across all the different people. Another key piece is just the care management meeting framework. And so we have monthly meetings where all the different entities that touch our patients and touch our work come together, and we have a whole variety of different things that get discussed, but it's an opportunity for people to stay connected, to troubleshoot real cases that we've shed light on through our own work or through their own work, or through our partners' work, and have some camaraderie continue to build on the side. So one of the key things that we get asked, and especially myself as a data person, is how do we measure and evaluate this work? And so just going to talk briefly about that. And so who here has started a program in their respective work, and not being told exactly, I need you to do X, Y, and Z, but giving you some freedom to define what that program looks like. I see hands going up. So when we started this, it was a relatively new space. We hired a social worker, we hired a nurse practitioner who were going off and kind of, they were taking notes in notebooks, and there was no structure to the whole thing. And so at a certain point, we realized that we needed to scale up. And I think the turning point in our head was we got one of the CMMI innovation grants about 4 or 5 years ago, which really had, concrete numbers, and we had to scale. And so that was the sort of moment where we're like, oh, what we're doing is great. We totally, the work that our clinical staff are doing, but for us to sustain this, you need to be very structured around it. And so we had a very deep dive with what is it that we do as an organization or as a care team. And so lots of brainstorming, lots of person-centered design or ideation, lots of the buzzwords flowing around, which results in a lot of Post-it notes. That's, I think what they all say is these are Post-it note sessions, and Post-it is behind all of this work in the back end. But so you take those Post-it notes and then you organize them into nice, pretty designs that map out the flow of people through the system. And then, at its core, it's about how do we then use data to support and enable this. And so, we developed very protocolized workflows that, here are the very, the steps from, hospital, somebody's been hospitalized, to the triage, to the bedside engagement, to the home. What are the points that we want to be tracking? What are the assessments around them that we want to be doing? And, laying that out in a very structured manner. One of the biggest pieces is just how do we make this as simple as possible for our care team staff that are doing this very hard work of building the relationships, of being confronted with very complex situations day after day. And so we spent a lot of time developing a system that meets their needs. And so this is all in that bottom left of the data systems diagram I was talking about. We built out a whole care tracking system that our data team are constantly sitting next to our care staff and going back and forth and probably getting way too many requests, and we should be more structured, but we are very receptive in what their needs are. And so we give everybody iPads, I know that that's a Samsung, and they're going out and they're tracking every piece of the data that they need to be doing. And what that allows us to do is, because we have that claims data and a whole variety of other data sets, we can then have a really readily accessible window into how are we performing. And so we take that program level data of, who did we enroll? Did they get this kind of, did they get a home visit in this interval? Did they get a primary care visit? How long did we engage them? How many contacts? And we can start to connect the dots. And so this is what I was mentioning earlier, where early on it became very clear that your days to your first primary care visit and an initial home visit was really a profound two things together. Even in isolation, those separately, they were good things, but when they happened together, it was a really powerful reduction in readmission rates. And so that's become a key performance indicator. I'm sure that jargon has been, that word has been at the forefront of many people's minds as well. How do we take those key performance indicators and turn them into actionable things that we can have meetings and conversations around? And so taking that performance metric here is every circle is one of our patients on a panel at one point, and you can start to break it down by the team lead. And on one axis is, are we getting them to their home visit within the desired window? On the other axis, are we getting them to the PCP? And you can start to see, well, yes, there's many that we're having success with. Here are the folks that we're not. Our care team staff can click in, they can see who those patients are, bump them up to the top of their queue, and start to really prioritize them. Another piece of this is just the evaluation side of things. I'm sorry, just a quick time check. I see time is up. Okay, so we'll get to the questions quickly. I'm going to go quickly now. I apologize. And I'm from New York. My dad is from New York, who I didn't mention, so I can talk very fast. But at the individual level, we have lots and lots of anecdotes of people being successful. But what we need to do, and this is just one case where someone had really high utilization, you can start to see the intervention touch points. And as the intervention got rolling, someone who had 5 or so admissions and has no more hospitalizations. We've done some aggregate level analyses, and you can start to see some, really significant changes. One of the things that you have to be cognizant of is this idea of regression of the mean and people getting healthier. And so we're in the midst of a randomized control trial, and I'm actually proud this is the first time I've presented since we completed our enrollment. So 800 individuals, or a little over 800 over 3+ years. We're following people for 6 months, and there's a little bit of lag for data generation, but hopeful that this will be a really effective, robust evaluation into this space. And we're working with the folks up at JPAL, MIT, who are really great evaluators. And if you're in this space and you're looking to do randomized evaluations, they are all ears, and they've been a tremendous partner on our end. And I'll skip over this one. This is just a subset of our program. We've implemented housing first vouchers, and so we've still found that even, this is going back to the data analysis, if people are chronically homeless and housing is one of the biggest barriers to getting people stabilized. And so even within our program of complex patients, we've started a subset that we give housing vouchers and a longer term supportive services piece. And you can see the blue line is when people moved in. We now take a 2-year pre-window, and so 2 years is a little bit more robust to regression of the mean. If somebody's continually going over 2 years, that's a much more likelihood of someone going again, and we're seeing 60% roughly reductions in hospital visits. And so starting to really see profound impacts. And so just the last piece I wanted to talk about, actually, do I have 5 more? 10 minutes? This is where, okay, so by show of hands, I can either talk about 2 things real fast. One of them is our efforts to do state transportation policy work. That's pretty short, it's a couple minutes. The other one is we've now spanned not just from hospital work into the criminal justice space and have data sharing with the police and with the county jail. So transportation policy, a few people. I will talk to everybody here who wants to talk about transportation policy ad nauseum at lunch or afterwards. So it seems like, can I get the show of hands for the criminal justice side? I'll go quickly, I promise. Okay, so it seems like it's more relevant. I saw opiates on parts of the later agenda, so I think it'll, long story short though, is just Medicaid transportation is important. The system's a mess. We got access, befriended the state and became an ally, and how do we support them? When we got access to all the administrative data, for a few $100 million contract, it was a mess. And we spent a whole bunch of time trying to improve how they could design their system, or how they, it was a whole bunch of community organizing that ended up changing a lot of the different aspects of how we do non-emergent Medicaid or medical transportation. So real fast though, so at the core of our care management intervention, there's a few clinical aspects of it, but in that sort of conversation over social determinants, most of what we're doing is helping people navigate the social services and other needs that aren't as much clinical. And so here you can see the different domains of care, that all those different needs that start to get articulated by the patient at bedside that get mapped up, these are what drive our work. And so most of them are non-medical. And so when you only have the claims data, obviously everything seems medical. And as I said, for all the reasons, claims are great, but they're not going to tell you the full story of what's going on. And so over the past couple of years, we've started an effort called Camden Rise, which is expanding our lens to health and non-health partners to understand not just how people are moving across the health system, but the broader systems. And so we now have data sharing with the police and the jails. We have more recently the school districts coming on, and we're doing some interesting work with them. And really that's coming together in a really profound way of how do we bring more and more partners to this table to start to think about what that looks like. And so here you see us signing that data sharing agreement with the police. Here's the chief of police, who's been cited as a great advocate for community policing. One of the things that was key to that was how do we start to speak the language that the police are already telling? Police are responding to overdoses, nearly daily, sometimes multiple per day, and so obviously that's something, they've all gotten trained in Narcan, they're learning more about addiction. So we said, let's talk about, what does addiction look like in your data? And so give us your data and we'll start to tell a story for you guys. And so here's one person that they responded to for an overdose in 2014 or 2014. And all those different bars are encounters that person had with the healthcare or police system even before and after that interaction. And you can start to look at the codings and you can see, okay, that person who they administered Narcan to for a heroin-related overdose also had multiple hospital-related overdoses years back, and has had multiple substance abuse and related hospital stays, has had drug charges. So that same individual level trajectory that I showed earlier, this is not someone that just shows up and is admitted to the police. And so this is really a good way to start to get the police into the conversation. Show that person of one, and then show them for a given year, here's everybody that you've had to administer Narcan to, and here's their utilization trajectories. And you can see overwhelming number of those people have been seen by the healthcare system for an overdose or something else substance related. And so, this is an opportunity to start to get there earlier. And so we got access to their data. We were able to show that of the people who are arrested, a large percentage, 66% roughly, have had hospital-related stays. Again, we're focused on the outliers, so who are the people at the extreme end of that? And so started to get the distributions and look at the folks who have 16 or more ED visits in a year, the top 5%, or 7 or more arrests in 5 years, and the top 5%. And again, start at that N of 1 level. Here's the trajectory that I showed you earlier, now supplemented with the criminal justice side. And you can see in addition to all those hospital encounters, you're now seeing 20 or so arrests and a similar type of progression, petty theft and shoplifting that then results into a violent related arrest, a couple of jail stays, the heroin overdose that the police respond to. And so this continues that story and starts to expand even more partners so that they understand how they tie into it. Getting back to the segmentation, you can bring in diagnoses, you can bring in criminal justice, your arrest types, and you can start to see that not just because you have high utilization makes you a homogenous person. There's a lot of different things that are going on, and so you can do cluster analysis, fancy math potentially involved, but we can talk about it, and you can start to tease out different types of groups that fit within that extreme cohort. So it might be nonviolent, medically very complex drug offenders tend to be male, and when they're committing crimes, it's not a violent related crime, but something substance abuse related versus assault. There's a cohort that is the pink cohort that you can barely see the text for, but assault victims with lots and lots of mental health complexity and addictions that are committing more violent crimes that interestingly tend to be skewed much more heavily towards women. And so lots of sort of, okay, if I'm going to develop a program, I need to understand who my population is and what are their specific needs. And so more and more, we've taken our model, which is born out of the healthcare system, and when we brought in that criminal justice data that I mentioned, we found that, we thought, we're talking people in their 50s, we thought criminal justice involvement was 20, 30 years in their past. It was a barrier to why they couldn't get access to some housing or employment, but we didn't think it was current. We found that a large percentage of our population had current criminal justice involvement, and when they did, our graduation rate dropped from 70% to 44%. And so realizing that we needed to do more to figure out what that looks like, we started engaging foundations and other organizations around how do we take our model and try and pilot it in the criminal justice space. So with the data, we were able to explore different population criteria, understand how those individuals were, what the daily census of people in the jail that met that, so we could start to see what do we actually have the capacity to serve in this pilot phase. We could start to map out each of those persons' trajectories to see, length of stay-wise, are people in there for a long time? How much time, if we're going to do that same kind of bedside engagement that we do in the hospital side, would we need to, interject into the jail system, what that would look like? And so lots and lots of interesting stuff to come, and I'm happy to talk more about it. We also have the Accountable Health Communities Grant, so in this social determined space, this is one of those things that I hope that if you are in this space, come talk to me. I have lots of, challenges and questions, and also hopefully some insight as well around there, as well as Promise Neighborhoods, one of our partners. This is where I was talking about with the school district. We now have, we're working around how do we bridge the intergenerational poverty gap. And so we have data sharing agreements with the school district, and we're looking at chronic absenteeism. And who are those kids? Are they in families that maybe their older siblings or an older generation is starting to become high utilizers, or their parents are, have a similar type of, we think it's a very much multi-generational type thing. And so excited about the potential that Promise Neighborhoods can add add to this data. So with that, I'm very sorry I went over time, but I have an email address, and I have, I think, a time for 5 minutes roughly of questions. So if anybody is excited to ask a question, thank you.
Aaron, thank you so much. Don't go anywhere. Don't go anywhere, Aaron. Thank you so much. A presentation that says scatter plot, randomized control trial, and community organizing really hit all the marks for me. I'm going to take the first question for Aaron, and we'll have time for 2 audience questions. There's a mic roaming, so if you have a question, be ready with your name, your organization, and a brief question for Aaron. So just raise your hand. The first question, Aaron, do you have any allies that were unexpected, a favorite ally, or a dream ally that you would want to work with in this organization? If you would name them and maybe a little bit of how you came to work with them.
Sure. So I don't want to play favoritism of our allies, because I did hear that this was being recorded. I mean, I think that the school district has been a really interesting partner in that they have articulated their own agenda of addressing chronic absenteeism as much as possible. And so while they were off our radar, they were very proactive to us around how do we get over the FERPA barriers, how do we start to share data, and they we actually stood up with them a whole overhauling of their absenteeism program, where traditionally they were just sending out letters telling their parents or guardians that their kids had 3 days absence, 5 days absence, 10 days. It was a very ineffective model. And then, oh, we'll see you in court. And so we had someone who was very much bought in to the idea that data is meaningful. They had an agenda, and it was just about trying to figure out how we could latch the work that we're doing into that. So this whole idea of how do we look at those kids on the healthcare side, and what stories do we tell? And we would imagine that we'd see similar poor health outcomes that you would see for the chronic absenteeism side, or how do we start to look at the multi-generational aspects of this? And so there's one of the lessons we've learned is there is at every institution somebody who wants to be doing data-related work. It's about lots of years of trying to find that person and turn up rocks, or if you do know who they are, cultivate the relationship, empower them to try and smooth this along. Because the conversation we're having around data sharing within one organization over, okay, you have the superintendent bought in, but now you have the general counsel, and you have school principals who are all key to this work succeeding, and they all need to be bought in. And so finding those few people and trying to empower them as much as possible and listen to what they're telling you.
Questions in the audience? Here's one. And again, Aaron will be here through lunch. You have
through
his
the end of the day, and I will be happy
email
to.
address, so feel free to call on him with your questions about this topic, because he covered a lot of information this morning for us. So if you would just state your name and organization, thank you.
Dana Manning, University of Kentucky. I have found that if you want to get good data analysis, you need to have people in your organization that are data analysts, data visualization people, et cetera. So I'm curious, how many people in your organization are dedicated just strictly to doing the analysis and other associated tasks?
This is something that I think a lot about, of how do you form a data team. And so when we started the coalition, there was myself and maybe one other person who were data people. And again, I'm not a PhD level researcher. My background's on computer science. I understand SQL and can do some of those pieces that are important. But you can start at whatever level. And so there's a lot of this work could be done in a Microsoft Access database where it's not very complicated. And so there are ways to start small. That being said, to get to the scale that you need to be, you need to have a whole variety of different staff. And so right now we have roughly 8 or so data people, depending on how you define it, that touch everything from our health information exchange to our the longitudinal data to the case management tracking software. A big piece of this is also that we know that there's so many more analyses that need to happen from this data. So we have been using it for our specific purposes, some of which I've outlined today. There's a whole variety of things that people have come out and said, oh, if we can only do this or this, and we said, that's great. We've spent all of the effort to organize that data, to clean it, to understand where it's good and where it's bad. How do we create a governance model that if I'm a researcher, in our case at Rutgers, who has a question around school performance over the summer and summer slip, that because we have this education data, even though it's completely not relevant to the the concrete work that we're doing, we can create a platform for them to use it, and then also hopefully potentially feed us back if they've cleaned this variables or they figured out these things. So I think wherever you are starting, there's a place and there's a way to sort of expand the team. But yes, you need some people that are pretty understand data and information architecture pretty well.
Thank you. If you want to talk with Aaron about the governance models, because that's a whole nother conference that we need to talk with, please speak with him. I want to keep us on track, on time this morning. Please help me thank Aaron for his presentation this morning. Next to the stage, I'll welcome back Jennifer Chubinski, and if our session 1 panelists can join us in the front, thanks so much.
Rochelle and Susan are not going to let us leave the room, so we're going to take a quick stretch break. If everybody would stand up, let's practice some active applause for Aaron, who was amazing. Thank you very much. If you would